behalf of the American Heart Association and Know Diabetes by Heart, I would like to welcome you to today's webinar. My name is Sarah Duckett, and I'm a program consultant for the American Heart Association. We are excited to provide you with some important updates to AHA's Target Type 2 Diabetes Outpatient Recognition Program under the Know Diabetes by Heart initiative. We are thrilled to have a member of our AHA Outpatient Quality Advisory Committee, Dr. Dana Weishar, who is a part of the evolution of our new clinical practice questions. Dr. Weishar is an advanced heart failure and transplant cardiologist at Kaiser Permanente in Santa Clara, California. We are so thankful to have her and look forward to hearing from her a little later in the presentation. Before we get started, I'd like to review how to use this webinar platform for today's event. If you would like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. If you require live captioning services during the webinar, please visit the link in the audience chat. If you have questions during the presentation, please use the question feature in the attendee control panel. Please review our disclaimer and disclosures. Dr. Weishar has no personal disclosures or conflicts of interest. Today, I will be providing you with a background of the Know Diabetes by Heart initiative and speaking to you about the Target Type 2 diabetes quality programs associated with this initiative. For the clinical portion of this presentation, Dr. Weishar will provide an overview of the updated standards of care in diabetes from the American Diabetes Association, and then she will walk through the science behind the new clinical practice questions and then review them individually. We will end our time together with a Q&A session. I would like to start off by looking at a few statistics related to diabetes and cardiovascular disease, as it helps set the tone for why we're here today. First, patients with type 2 diabetes and kidney disease are at a 3-time higher risk of dying from cardiovascular event. Secondly, only about a third of people 45 and older with type 2 diabetes have discussed their risk with their healthcare providers for developing heart attack, stroke, or cardiovascular disease. These statistics bring to the forefront the importance of the Know Diabetes by Heart initiative, which focuses on improving quality of care for people with diabetes and providing resources and support for both healthcare professionals and patients. I'd like to provide more of a background on the Know Diabetes by Heart initiative. Know Diabetes by Heart is a joint initiative between the American Heart Association and the American Diabetes Association, which aims to help people living with type 2 diabetes lower their risk for cardiovascular disease by connecting them and the healthcare professionals who care for them with education and resources. There are 3 pillars of focus within Know Diabetes by Heart, which are quality improvement, patient engagement, and professional education. More than 34 million Americans live with diabetes, and 90 to 95% of those are living with type 2. So this means that more than 30 million people in the US live with type 2 diabetes. So with all that being said, this is no small task, but it's an extremely important one, and one that can't be tackled by one organization. So we have strategically aligned with ADA to bring to the forefront CVD and CVD risk in people living with type 2 diabetes. Know Diabetes by Heart is made possible with support from founding sponsor Novo Nordisk and national sponsor Bayer. So where does AHA's Target Type 2 Diabetes program fit in here? These programs fall under the quality improvement pillar of Know Diabetes by Heart. Target Type 2 offers programs for both inpatient and outpatient. If you're in a large health system, you may be familiar with our inpatient Target Type 2 Honor Roll Recognition program. This program aims to ensure patients with type 2 diabetes receive the most up-to-date evidence-based care when hospitalized with CVD or stroke. The Target Type 2 Honor Roll recognition opportunity is for hospitals participating in Get With The Guidelines, heart failure, stroke, and new this year, coronary artery disease. For today's presentation, we will focus on the outpatient program for Target Type 2, which is a recognition program for outpatient organizations providing related care to type 2 diabetes and cardiovascular risk factors. So let's talk about the criteria for the Target Type 2 outpatient recognition program, starting with who is eligible to participate. Currently, healthcare organizations that are directly diagnosing and treating patients with diabetes, including prescribing and managing medications, qualify for participation. There are two levels of recognition, participant and gold. The participant award recognizes organizations who submit data annually and are committed to improving and addressing CVD risk in patients with type 2 diabetes. For gold status, organizations must fulfill the participant criteria and are high achieving in the required reporting measures. The first measure is diabetes poor control, defined as an annual rate of 25% or less of diabetes patients who have an A1C greater than 9. The first measure is required for all organizations. In addition to the diabetes poor control, organizations must demonstrate a 70% or greater performance in at least one of the two CVD risk factor measures, including statin therapy or blood pressure control. So two measures must be submitted. However, one of them must be diabetes poor control. So what's staying the same within the program and what's changing? The award levels, the award criteria, and the diabetes measures will not be changing. But what will change is the self-assessment questions, which will be the focus for the rest of this presentation. At this time, I'm going to pass the mic over to Dr. Weishar so she can share the new clinical practice questions and the science behind them. But before getting into the questions, Dr. Weishar, can you please talk to us about the recent updates and changes that came out this year from the American Diabetes Association related to the standards of care for diabetes?
Thank you, Sarah, for that introduction. And as she mentioned, my job today is to review some of the updates that are found in the 2023 version of the Standards of Care for Diabetes document that is published and updated annually by the American Diabetes Association. And specifically as it relates to the work from the American Heart Association on the interaction between diabetes management and cardiovascular risk. So there's an increased emphasis on support for weight loss, also an increased emphasis on identifying and considering social determinants of health. There are new cutoffs for hypertension and the role of some newer medical therapies that we'll go through, and a focus on lipid management as well. Because of these changes in the guidelines, the outpatient quality group has modified the No Diabetes by Heart initiative with some updated questions from 2022 to 2023 and a couple of new questions, which we'll go through at the end. The vision that I think, or the visual that best addresses how we really want to have you think about diabetes care and how it builds toward better cardiovascular outcomes and better reduction in diabetes complications is well depicted by this pantheon with lifestyle modification and education of patients and understanding of patients' basic comorbidities and social determinants of health that really are going to help drive how we build these pillars of medical care. One around glycemic management, one around blood pressure management, another around lipid management, and one around cardiovascular and kidney benefit. Because while you might think, well, what does a cardiologist think about or care about kidneys? Well, they're really tied together and they really are part of the whole cardiometabolic milieu that's within an individual patient, and taking into account the kidney health as well as the cardiovascular health, because they're very circular and entwined, is important. And all of this, as I mentioned, in order to achieve the goals of better outcomes in terms of cardiovascular health and reducing the complications of diabetes. This is a very busy slide. I want to step you through it a little bit, piece by piece, because it basically reminds us as clinicians that we need to really, while we're standardizing several of the touch points on this goals of care circle, we really need to individualize it as well. So we need to take into consideration the patient's individual priorities, their social determinants of health that influence their access to medications, their access to healthy food, their access to medical care, their access to monitoring in terms of their labs or their blood pressure or their glycemic control. Understanding the individual patients' comorbid conditions as well as their clinical characteristics that are going to influence how the patient addresses their care as well as how the clinician addresses their care. Then we're going to make specific, in the red box, we're going to make specific decisions around individualizing the patient's goals. So what's their weight goal? What's their glycemic goal? How are we going to take into account the interactions, both side effects interactions and drug-drug interactions of the medication profile that we're going to put together? How complex is it? How often are they having to take medications? Are they able to take medications frequently? Do they have issues with memory and we need to really simplify their regimen? These are all things then are going to help us to come up with the blue box, which is really around shared decision making and creating a management plan, because our best plan doesn't work if the patient can't implement it. Once we've come to an agreement in the light blue box on the management plan, and here I like this identification of a mnemonic called the SMART goals. Is it specific? Is it measurable? Is it achievable? Is it realistic? And what's our time frame in which we're going to assess whether or not this therapeutic plan is working for that patient? Then we're going to implement it. We're going to submit the prescriptions. We're going to make sure the patient has access to their medications. And then we come back around and we reassess the patient to review the outcomes on terms of their lipids or their blood pressure or their glycemic control or their weight, or are they having side effects? So we need to modify the plan. And so we go back around this circle based on this continuous quality circle around what's working, what's not working. And it's not just what's working for the glycemic control and their lipid control, but what's working in terms of the patient being able to remember to take their meds, being able to tolerate the side effects, being able to afford their medicines, and all these other things that I think remind us that medicine is not just from a cookbook. It really takes individualizing the recipe for each patient. This slide is kind of a distillation in a similar way, but in a much more checklist focused presentation. It's in the standards of care in diabetes management guidelines. And it's really to help systems or individuals who are practicing to make sure that we are touching on each one of these points at the initial visit, at follow-up visits, and then annually, we need to really assess how well we're doing, because what is it, the definition of insanity is doing the same thing over and over and expecting a different result. So we really want to make sure that we're moving forward and we're making progress in the health of the patient. Okay, this slide is also quite busy, so I'm going to step you through it a little bit. It's a way to think about glucose lowering medications that we have now available for us, because it's not just one drug fits all. Again, toward tailoring it to your individual patient, we want you to think about on the left-hand side of the slide, does your patient already have known atherosclerotic cardiovascular disease? If they do, we really should start with a GLP-1 or a SGLT2 inhibitor as the first line of therapy for treating their type 2 diabetes. And then we want to reassess, and if their hemoglobin A1C is still above target, consider adding the other agent. If they have heart failure in the red column, you really want to start with the SGLT2 inhibitors because they have a proven benefit on survival in patients with heart failure. And the exciting part about that is it's not just HFrEF or patients with reduced ejection fraction, but also patients with preserved ejection fraction who benefit. Okay, there's my hat as an advanced heart failure doc coming out. We also want to consider their kidney health. If patients have an eGFR less than 60, which indicates they have some chronic kidney disease, we want to be really focused on using those SGLT2 inhibitors as well. If you have somebody who doesn't have known cardiorenal disease, then you can really start in a lot of other ways. And you really even start with individual weight management goals, lifestyle changes in terms of changing their diet, in terms of how much carbohydrate they're taking in their meals. We can consider medication for weight loss. We can consider metabolic surgeries, and we can use really any combination of hypoglycemic agents, not just focus on the SGLT2 inhibitors and the GLP-1 inhibitors that we really want to focus on for our patients who already have known cardiovascular or renal disease. Now, we threw this one in because if you're like me, I'm a cardiologist. I never remember these thresholds off the top of my head, so I definitely go to the standards of care in diabetes from the ADA all the time to remind myself of how we classify chronic kidney disease. And it's not just about your eGFR. It's also about whether or not you have microalbuminuria. So we really need to do both a serum creatinine, looking at the GFR, but also looking at the urine creatinine to albumin ratio to really get a sense of where they fall in here, because you can have a normal eGFR but moderate albuminuria and still be considered someone who has CKD. So it's the combination of the two that really put you on this map and really define then your risk of cardiovascular disease related to your kidney health. So sorry about that whirlwind overview of the data around cardiovascular disease, diabetes, and renal disease. But those are really the things that then caused us to change the questions within this program. So you'll see that question 7, which is an old question, has been modified with this blue box of new selections that really focus on adding in social determinants of health and opportunities for an organization who's participating to highlight other characteristics that we haven't thought of, or to put, well, we haven't really considered it as a check option. We also have updated the question 8 to allow for a little more transparency in terms of answers from each organization. This is about operationalizing treatment plans, because like I said, on that continuous improvement circle, it's really about finding a treatment plan that is individualized for a patient, and what are our processes around helping patients get a plan that works for them. And then prescribed therapies, as we mentioned, there's a lot of different therapies for cardiovascular health as well as for renal health. And so we really want to focus on the use of angiotensin receptor blockers. Those are either ACE inhibitors, ARBs, or ARNI. Other antihypertensive medications, lipid lowering therapies, and then each of these different newer therapies for glycemic control, and asking for each one of these where they're prescribed, who's prescribing them, whether there are barriers to prescribing them in the data collection. and here's where I was talking about identifying what those barriers are to treating specifically with these cardioprotective or cardiorenal protective medicines, such as the SGLT2 inhibitors, GLP-1 agonists. Sorry. I think I keep saying inhibitors, but I really mean agonists. And then finally, there's a question about evaluating kidney health. And this is one I think that's least intuitive, but when we really think about management of diabetes in order to lower the cardiovascular risk and complications from long-term diabetes, it really is impossible to separate your stroke risk, your heart attack risk from your kidney risk. And so we are including the kidney into this framework by asking, how do you assess for renal vascular health in terms of that grid that I showed you with the chronic kidney disease? Because it's really not just about glomerular filtration, but it's also about that albumin creatinine ratio in the urine. So that this question gets directly at that because it's part of the whole cardiometabolic triumvirate, if you will. Okay. Summarizing, my clinical practice takeaways from this presentation are that the modern management of diabetes is not just about lowering glucose. It's about protecting the heart, the brain, and the kidneys from vascular injury. So in addition to the hemoglobin A1C goals, it's important to track weight, activity, blood pressure, lipids, renal function in all diabetics. And in 2023, we have a broad array of tools for diabetes care. And our job as clinicians is to tailor that care to the patients individually. And that we at the AHA remain committed to educating, guiding, and elevating healthcare systems to provide the best care for patients with diabetes. And we proudly recognize those who demonstrate adherence to these guidelines and are successful in moving the needle for our healthier population. Thank you.
Thank you so much, Dr. Weishar. That was so helpful. Just love learning about all of that information. So we're going to shift now. If your organization is ready to be recognized, I want to walk through some steps to do so. So the first step would be to register online for the Target Type 2 Diabetes Outpatient Program. If you have registered for this program in the past, you do not need to re-register. After registering, you will then submit your data through our IRP platform. The data submission window is now open and will close May 19th, 2023. Finally, you will be recognized for your achievements through the national recognition, which occurs in the fall. The recognition window that closes that is for recognition from last year. I just wanted to point that out. To help you along the way, we have many great resources to guide you through the data submission process. First, we have a quick user guide, which provides you with a step-by-step guideline for data submission. We have a data collection worksheet, which provides you with the required data needed for submission, an FAQ, and a resource guide, which provides job aids, citations, and many more resources specific to the new clinical practice questions that Dr. Weishar just went over. I have put some of these resources in the handout section of your attendee control panel, so you can access those there, or you can also go to our website, which is listed on the screen now, and access those through the website. And lastly, on the No Diabetes by Heart website, we have a multitude of professional tools and resources, as well as patient education materials. So at this time, I'm going to pass it over to Catherine Overton, National Director, Program Development Outpatient, for our Q&A session.
So I wanted to come on and help support the Q&A session here. I wanted to say thank you to Dr. Dana Weishar for helping us through this webinar. One of the first questions we have was, how do you, Dana, this is specifically for Dr. Weishart, how do you help your patients overcome barriers to understanding medications that you're prescribing? So we saw this whole new emphasis on these newer therapies, some of which are, injectable therapies or can be, part of a very broad treatment plan. How are you working with your patients to understand these treatment options? And do you have any kind of tips for organizations and their patient-centered conversations?
My personal take on it is really about listening and educating, listening to the patients about what their goals are, and then making sure that my goals are aligned with theirs. And sometimes patients just like to hear that my goals, if they come in and I say, well, my goal is to help you live longer and live better, and here's how I want to do it by helping you lower your hemoglobin A1C and your cholesterol. It's a lot easier message than your cholesterol's too high, I want you to take a statin, or your blood sugar's too high, I want you to inject yourself. It really kind of aligns the end goal with something we both want, and then we can kind of negotiate or figure out what it's going to take to get there. And as a heart failure doc, I do this a lot with my heart failure patients, and I'm talking about SGLT2 inhibitors and Entresto and other heart failure meds, and have to really listen to what patients' experience has been with the medication before. Why didn't they tolerate it? What are the barriers in terms of affording the medicine or compliance? If it's a twice a day medicine, why do I really have to take it twice a day? So always starting with, what are your goals? What are your concerns? What are your issues? And then making sure that I'm aligned allows me to educate the patient about how this recommendation is going to help us meet our goal.
Thank you for that. For the next question, Liz, if you wouldn't mind going back to the medication question slide, I think it'll be great to have this slide up as we talk about why we've added this question to the recognition. That's it, perfect. We have a question related to how to help organizations and providers consider some of these newer therapies. I know that a large % of our organizations that participate in Target Type 2 diabetes are in the family medicine space. Oftentimes they're in the federally qualified health center space. And so before I turn the floor over to you, Dana, I wanted to kind of talk a little bit about the organizational reasons at AHA we decided to include this question. For one, when you actually go to do your recognition form, the way this question is presented is it's each of these medications and then medication classes rather, and then where these medications are happening in your health system. So if you are just perhaps like a single specialty organization such as family medicine or cardiology, you may only check that box for a medication that your organization is prescribing because it doesn't fit your structure, right? You can't necessarily speak to endocrinology because you're a family medicine organization. But the intent of this question was for us to really understand how the AHA can support organizations because we find that there are a lot of organizations that don't have access to some of the newer therapies. They're not part of their formulary. They have prescribing barriers related to policy situations in their state or in their organization alone. And we wanted to really first understand where these medications were happening. And in large health systems where maybe you have family medicine, cardiology, endocrinology, or specialty clinic, we see newer cardiorenal metabolic specialty clinics or perhaps lipid clinics that are also intensifying medications related to the general wellness of cardiometabolic health. We wanted to give you opportunity to kind of tell us where intensification is happening and tell us where medications were happening. Because we think that they're not happening everywhere, right? We think that some maybe family medicine organizations are feeling more comfortable in referring for certain medications or therapies, or maybe they, again, just don't have access to prescribing some of these due to formulary restrictions, which is addressed in question 9 as one of those barriers. But how are you feeling in this space and working with your colleagues around some of these newer therapies? Do you, and also I'll add in my own question, do you have your own institutional barriers sometimes with some of these therapies?
Yeah, I work for Kaiser Permanente, which is a very large organization, and we work very hard to disseminate information and best practices. And the uptake is variable. There's always early adopters who are on the bandwagon from the minute a new guideline comes out, and then there are those who kind of wait and see, or it's just kind of hard to change practice. And so variability exists. I think what we really want to do is we want to understand kind of where it's happening in each organization, because I think in your own organization, understanding who's doing what and what are they comfortable with can also help you focus your quality improvement internally to raise the bar. You know, we want all boats to float to the highest level. And so if something starts out just in endocrinology, that's fine. Do we have a process for getting those patients to endocrinology when that's the best therapy for them? And when it's a tool that is more comfortable, like the ACE inhibitors and ARBs that have been around for quite some time, and the data is coming out that they are renal protective as well as very important for patients with heart failure, of course. Those are things that I would expect our family practice, primary care practitioners to be really good at. And if there are barriers to them using those tools, what are they so we can overcome them?
That's a perfect segue back to question 10 of some of the barriers. I know there's a lot of text on these slides, and as Sarah mentioned, we have multiple resources to help you understand these questions and what all the materials are here. But if you haven't downloaded those yet, which are available on the websites and also I believe in the handout section, we wanted to share this a little bit longer related to some of the barriers that we know exist from feedback from our own volunteers and their own institutions, but also from feedback that we've heard from participating organizations. So you mentioned that prescriber reluctance to modify patients' medications, that maybe clinician awareness of the changes in the guidelines, still waiting to listen and learn and see how things are going before embracing that evidence. Sometimes just lack of access to referrals can be a difficult barrier, especially I would imagine for rural health organizations. Making sure that there's providers that can support these patients that need intensification or patients that need access to therapies that may not be in their toolboxes. Are there anything here on the slide with these that are you would like to comment on more? I just wanted to give it one more second of floor as we let the audience see this slide a little bit longer.
And no, I was just, as you were talking, I was thinking too about the time. Time is a really important barrier to change, especially when you're changing a patient's regimen. A patient may need that extra time for you to explain why it's important now to do something that you didn't ask them to do last year or the year before. But now the data is stronger for SGLT2 inhibitors or for ARB or whatever it is that you're recommending. So being able to put it in a context for the patient about what the benefit is. Another good example is that a patient who's obese, getting them to adapt their diabetes therapy in order to help them with their weight loss. And so having that conversation, especially when you're talking about an injectable therapy where the patient may be reluctant to move to an injectable, but oftentimes if you tie it to, these are meds that are helpful with weight loss, suddenly they're a little more eager to try something new.
Yeah, that's a really great point. I have a timely question here in the chat about, we've been talking about intensification, right? When is the right time to start de-escalating treatment that have reached their A1C goals? How do we go about this, and how do you approach this?
I really think I go back to, again, what are the comorbidities that the patient's facing? If I've got somebody who's reached their A1C goal I sit with the patient and I say, okay, great. We have arrived at a place that is really going to help you live longer and live a better life with fewer complications, a lower risk of stroke and a lower risk of kidney dysfunction. Now that we're there, you've lost weight. Maybe we can come off the GLP-1 inhibitor and see if on the rest of your regimen, you're still stable. But I may not want to ever de-escalate their statin therapy, especially if they're someone who is a secondary prevention patient. So they're patients who have atherosclerotic disease, and we know that a statin for long-term is helpful. Where the other place where we get into de-escalation is when we get to the elderly folks. You know, at what point is it really necessary to keep your LDL down? You know, when you pass 80, maybe, or when you pass 75, where is that cut point where we can start changing our therapy, because we're no longer looking at those decades-long, perhaps, gains that we get from cholesterol lowering. We still want to keep them healthy, but we might start running into other issues as our patients get older.
And this is a question that I think kind of goes along with in the same kind of de-escalation pattern. The question is diabetes type 2 specifically reversible? Reversible is the key word here, reversible.
So technically, so it's kind of like heart failure with reduced ejection fraction. It never goes away, right? So you always have diabetes, even when your hemoglobin A1C is well controlled. Now, can you control it with diet and exercise and weight management alone? Potentially. So once you've lost the weight, once your hemoglobin A1C is in control, you may be able to de-escalate to lifestyle changes alone and not medical therapy. But many of those patients are still, when you take them off the medical therapy, their hemoglobin A1C is going to climb. It didn't go away. We're just controlling it. So I had this conversation just a half an hour ago with one of my patients. He said, I stopped my antihypertensive because my blood pressures were great, but his blood pressure is high now. So even though he lost weight and he's exercising, those are not enough to keep his blood pressure under control. He needs to take antihypertensives. Same thing with lipid control, same thing with diabetes control, same thing. So, and I make because I'm a heart failure doc, I make the analogy to cardiomyopathy. We know that cardiomyopathy does not go away, even when the ejection fraction normalizes. So if you stop the medication, it might not be today or tomorrow or a year from now, 2 years from now, but the cardiomyopathy is going to come back, or is always there, and it's going to decompensate. So there are many conditions where you need to have lifelong monitoring and lifelong management. Diabetes is one of those. You need lifelong management. So once you're a diabetic, you're always a diabetic. It's just a matter of how do we control it.
The next two questions I have are related specifically to patients with ASCVD. And I guess the first one's not quite a diagnosed secondary prevention. The first question is ASCVD 10-year risk. This person noticed that it was added into one of the questions and wanted to know, why is 10-year risk calculations, that ASCVD 10-year risk calculation, important for patients with diabetes?
Great question. Well, it's because our risk calculators are based on a 10-year risk factor. So part of the practical answer is that if you want to calculate a patient's risk, we don't have a risk calculator that calculates their 5-year risk. We have a risk calculator that calculates their 10-year risk. So all of our guidelines are written around identifying patients, and particularly around lipid lowering therapy, are around patients who are in an intermediate or high risk of 10-year risk for atherosclerotic disease. So if you're in a low risk group, you don't bother treating with statins. If they're in a high risk group, you treat with high intensity statins. And if they're in that low or in that intermediate risk group, this is where we have to do some conversation and some tailoring based on your lipid profile and your
risk factors,
blood pressure and things like that.
Yeah, risk factors.
Right.
So I think the clarifying part here is, that the 10-year ASCVD risk calculator is not necessarily, it's not about type 2 diabetes really at all. It's about assessing the long-term ASCVD risk for patients with all of those risk factors, such as hypertension, dyslipidemia, and the type 2 diabetes, right?
Right. Like I said, these are really inseparable. We have to separate them in an organizational standpoint in order to measure them and measure the impact. But the reason why the AHA is partnered with the ADA, is partnered with the Kidney Association, is because they all are intertwined to define this cardiometabolic health of the individual. So yes, thank you. I missed that subtlety in the question.
Oh, no, thank you. And the next question also related to ASCVD. We know that ASCVD and diabetes are concomitant diseases in many patients. How do you manage patient expectations when trying to tackle both of these chronic diseases simultaneously? And how do you kind of weigh the kind of the fight between the two?
It's a challenge because a lot of patients that I run into really put a lot of weight on the number of prescriptions I have and the number of pills that I take in a day. We really have to go back to that conversation about, are our goals aligned? My goal is to have you live better and live longer. If I want you to live longer, there are some things I know will reduce your risk of another heart attack or another stroke, or as a diabetic are going to reduce your risk of your first heart attack or your first stroke. And then I have to break it down and say, okay, so this is the medicine you're taking for your cholesterol, and we've got you on the maximum dose, so we need to control your LDL more, so we're going to add this medicine. And then also focusing on, here are the ones that are for your diabetes. But I have to really show them that it's important to really pay attention to all aspects of that scale, or I sometimes liken it to a table. Like, if I ignore your sleep apnea, but I only take care of your diabetes, then I'm not really doing you the best good, because you're not balanced and you're not stable. So managing cholesterol and blood pressure and diabetes and weight, right? Probably the 4 really key pillars on most of my patients. Is we can't really ignore them, but we can start with one. Like, wherever the patient is, like if the patient's really not ready to tackle all 4, fine, let's start with one. And you might pick the one you think is the most impactful for the patient. Your hemoglobin A1C is 11. Let's work on that first, because it's not necessarily about doing it all at once, but getting the patient to want to take the therapy because our goals are aligned is really going to be the key.
So incremental changes, it sounds like.
Yeah, I want to do it all, and I want to do it all right now. I'm not the most patient person, and so I have to meet my patients where they are. And if they really want to take it one step at a time, then I need to do it incrementally. I have some patients who come in and say, I want to fix it, and I want to fix it all right now, and it's great. We come up with a really comprehensive plan, but other patients need time.
Makes sense, and appreciate that patient-centered approach. Let's see, let me check the Q&A really quick, see if there's anything else. Oh, we have a personal testimony of someone who, sharing their story of a reduced A1C, and really appreciated your comments on treatment plans and long-term support. No longer an insulin, and they felt the information was really great. So thank you to this person for sharing their testimony, and appreciate you being part of a webinar today. Let's see, one more question here. Let's see, actually we have 9 minutes left, so if you have more questions, keep them coming in. But I wrote down a question here of, it's related to the measures that I saw come through. And it was related to the blood pressure control and the the cholesterol management measure. And this is a question that was pertinent to the overall structure of the program. Thank you to Liz Montgomery, who was running slides on the back end, who was anticipating my needs here. And so the question was related to reporting the statin treatment measured, which is MIPS 438, and the controlling blood pressure measure. Their question was, Are we limiting the denominator of these populations to the diabetes population? And the answer is no. We actually want you to report these measures to the recognition program as they are written and specified. That will mean looking at statins and blood pressure beyond patients that are specific to type 2 diabetes. But I think this is also one of those all boats rise with the tide scenarios. It was an important question that the committee weighed a while back around ensuring that the programs were accessible to organizations and that we were not creating an undue data analysis problem. But we knew that these patients were going to be captured in the logic related to the statin therapy and captured in the logic related to blood pressure control. So we opted to maintain the intent of these measures. So if you are a data submitter and you are filling out the recognition forms for your data for 2022, you will indicate the numerator and denominator for those measures as written, and you do not need to limit them to the type 2 diabetes population. All right, let's see. I wrote another question down. This was a really great question. It was early on in the chat. It said, my organization was a small organization. We don't have the operational efficiencies, it sounds like, to do all of these things all the time and do them with the best of our abilities as much as we want to. And I'm, kind of blurring the lines of this person's questions, but the intent of the question was, I'm not doing all of these things in the questions. I think it's the first, second, and third questions. Is that okay? And the answer is yes. Do what you can. The evidence-based practice questions here are for us to have an assessment of your organization and for you to do an assessment of your organization, to understand what gaps you have based upon the guidelines and to decide and to make practical changes to move forward. Also, we hope that you will be able to use the resources of Target Type 2 Diabetes and Know Diabetes by Heart to fill some of those gaps. So at this point in time, the attestation questions are not going to count against your recognition status if you are not able to check all of those boxes. We want you to use those attestation questions as a self-assessment of your care and your practices, and then think about ways to take steps forward. And we look at the data of the program overall year to year and look at what steps organizations are doing to move their care forward and if that's having changes and impacts to the control rates. And that actually really helps the AHA in creating all of these wonderful resources that you see on the slide to help better support your organization. So it's actually very important for us to understand if you have gaps, if you have barriers, and so that we can build these programs to suit your support needs, and we can work with you to understand your support needs.
I just want to reiterate, I think you can't get better unless you know where you are. So we don't expect everyone to start at the top of this ladder. We wouldn't waste our time if everybody was already able to do it 100% efficiently all the time. The idea is to get better at it, and it's to get better at it as an organization, as an individual clinician, as a population of patients. And so it really is about going back to that cycle of quality improvement, right? So it's a plan it, do it, evaluate it, and reassess, and see where PDSA cycle. And so participating in this initiative really gives you the opportunity to see where you are and to help you understand what your barriers are and define those barriers, and then to articulate them back within your system to how can we do it better? How can we move that needle? Understanding we cannot remove all barriers for all patients, but if we identify barriers within our institution that are getting in the way of either our conversations or we don't have the educational resources, or what you have to figure out where you are and what it's going to take to make each next step get a little bit better. And it sometimes feels unfair because we come out with new science and so we change some of these recommendations and markers, but most of the time we don't change completely the focus of where we're going. We gradually just add on. So as you move forward, we're moving forward so that it's a continuous improvement for you and your patients.
I really appreciate that that framework and comparing the program structure to that PDSA cycle, which is a long time known quality tactic, because it's exactly the framework we're going for, right? At the AHA, we want to give organizations a place to benchmark how they are performing, to document that, to look and assess, and then continue to do that on that annual cycle and to make those incremental changes and have that opportunity to pause and say, are we moving forward? How are we doing here? So thank you, because it's a perfect
And
analogy.
I'll give you another practical tip. Sometimes too, depending on your organization, you can actually use that data saying we moved the needle from 25% of our diabetics being controlled to 30%. And that relates to a risk reduction of so many strokes or so many heart attacks across our population. And we do this in our organization. We put up banners that highlight those successes. Patients see those, see that the work that you're doing to control their cholesterol and their blood pressure and their kidney health will affect and lower their risk of having heart attacks and strokes. And sometimes that helps you to get that traction for patients to make the changes. So it all works.
Yeah, it's perfectly aligned with that, building the incentive for the patient, building the incentive for the providers, and just demonstrating the good work and all the changes that these organizations are doing. There's 2 questions left on prediabetes. I don't think we have time for them, but those who are in the chat with those questions, my commitment to you is I will try to figure out who you are and source those questions from Dr. Weishauer for you. I did want to end on one question that I thought was very important, and that question was, I saw there was a change in the recognition deadline. Can you please tell me what it was again? So Liz, maybe if you could go back to that slide, it's right there at the bottom of one of the slides, because we did change the recognition deadline. It is now, I believe, and I can't quote it off the top of my head there,
May 19th.
May 19th. So if you recall, oftentimes our recognition deadline butted up against the Memorial holiday weekend, and that was a really difficult time for a lot of people with, vacations and other commitments, end of year reporting, et cetera, or end of month reporting. So we have moved the deadline to May 19th, and that is a 11:59 Eastern Standard Time. So make sure to be mindful of your time zones. I will pause there. I want to say thank you again to Dr. Weishauer. We will get you those last final questions, and I'll send it to Sarah Duckett for closing.
Yes, just again, thank you, Dr. Weishauer, for your time today and sharing your wonderful knowledge and insight with us, and really helping us to understand the importance of looking at kidney health and the continued mission of educating about diabetes and cardiovascular disease. To the attendees, we really appreciate you coming to our webinar today. We're here to support you. We have email on the screen that you can utilize to send us further questions if you have them. So again, thank you so much, and we hope you have a wonderful evening.